Welcome to the pharmaphorum podcast. This is web editor Nicole Raleigh, and today I have with me Dr. Helen Thackray, Chief R&D Officer at biotech company BioCryst, as well as an alumnus of the Children's National Medical Center. Welcome, Helen.
Thank you, Nicole. Delighted to be with you today.
Now, around 75% of rare diseases are diagnosed in childhood, with most of those before the age of 2, with 30% of rare disease patients dying before the age of 5. The need for different treatment methods for children is very much clear, and Helen knows firsthand that children's patient preferences can be far more nuanced and complicated, from adolescents to those young enough to rely on their parents' consent, and that's why her team is focused on making first and or best-in-class treatments for rare disease patients, such as long-term oral prophylaxis that help to diversify the treatment landscape, empower the patient voice, and confront disease burden head-on. But before we commence that discussion, Helen, perhaps you could share with listeners a little bit more about your journey to today, the path that led you to do the work you do now with BioCryst.
Thank you, Nicole. I am a pediatrician, and I trained at Children's National Medical Center, as you mentioned. It was my experiences there with my patients and their families there that led me to understand how much more there is to do in pediatric care to make medicines available for patients and to have medicines that really change how they can live their lives. In my residency training, which was in a large city hospital, I saw a number of patients who had rare diseases, and I'm going to tell you about two of them in particular because it reflects some of the things that we'll talk about today. One of them was a teenager, a 14-year-old. It's actually the first patient I took care of in the inpatient setting, and he had cystic fibrosis. He died during the time that I was taking care of him. That was a devastating experience for his family, and it absolutely brought it home for me how important it is to find better treatments for children who are suffering with some of these very serious diseases. Another patient was a 3-year-old boy with sickle cell disease, and he was a very cheerful, playful 3-year-old boy, but he had had a stroke as a result of his disease, and it left half of his body paralyzed. And he was one of my favorite patients as a 3-year-old with a smile on his face every time I saw him. But playing, he could only use one arm, one leg. And I spent a lot of time with his mother talking to her about how she'd be taking care of him at home. Those are two examples of children who themselves and their families were seriously affected with a rare disease. And both of those diseases have new treatments available today that can improve the burden of disease and the suffering for them and for their family. It's that experience that really drove home to me that there's a lot more that's needed for the care of pediatric patients, and had the opportunity from there to work in the biotech industry and recognize that I could be working with teams that are developing drugs or devices that can improve lives for many more patients than the one or two I could see at a time as a pediatrician.
Thank you, Helen, and thank you also for sharing those personal experiences in your occupation there. It's very much clear that rare disease burden, unmet needs in that area continue, and indeed rare diseases are an emerging global public health priority, which is positive. But as we've been discussing, rare diseases typically affect patients from birth, involve multiple organ systems, are severely disabling, and can reduce life expectancy and impair physical and mental abilities. And as already stated, between 70 to 75% of these diseases have exclusively pediatric onset. 2 out of 3 rare diseases appear, as I say, before 2 years of age, and that can cause up to 20% of infant mortality and 10% of pediatric hospitalizations. So developing drugs for children with rare diseases is not only crucial to improve treatment options and improve quality and length of life, as Helen has been discussing, but also poses numerous ongoing challenges. Indeed, drug development in pediatric patients with rare diseases is typically more complex and much more expensive compared to the same programs in an adult population. Therefore, there has been incentivization for manufacturers to develop drugs to treat rare diseases, with regulatory authorities in the US and EU providing tax credits, grants for testing, and extended periods of exclusivity, for example. So, Helen, I was wondering, firstly, if you could tell us more about these.
These incentives have been very important, bringing attention from industry to the ability to develop better treatments for patients with rare disease. Perhaps one of the most important things that has changed is the regulations and the attention of the regulators to working very closely with biotechnology and pharmaceutical companies like mine, and allowing us to get into a dialogue early in the development process, in the drug development process with regulators to address some of those complex challenges that you mentioned. It is very difficult to understand how to test a drug in a disease where there aren't any treatments available. And it requires defining perhaps new endpoints to assess for effect, new endpoints to assess for safety for a drug in the clinical trial process. When you think about turning that to treatments for pediatric patients, you also need to think about assessing endpoints and safety outcomes for children who aren't able to speak about how they feel. And so that can be very complicated, and it takes time and effort to do that in the drug development industry. It's been incredibly helpful to have access to regulators to talk about what is most important to measure for assessment of benefit, what is most important to measure for assessment of risk, and the opportunity to work together with the regulators on defining a development program for a drug has been really one of the biggest changes in our ability to bring more treatments through. So that, to me, while the incentives have brought attention of the industry, it's the access to regulators to work with them on defining how to assess a drug's potential that's been most important.
Thank you, Helen. And this notion of collaborative efforts also I'd like to return to a little later in our discussion. But thinking about the assessment, I'd like to sort of shift and look at potentials if these routes are pursued. What can you tell listeners, tell me, about the possibilities there are to address some of the challenges we've been discussing by addressing age-appropriate formulations and perhaps recognizing the metabolic differences between children and adults?
Yes, let's return for a minute to the burden of disease and the burden of therapy. In pediatric patients, children, so think about my own children, as they've grown, it's always difficult to give them a treatment. It's difficult to give them an oral medication, or even to go to the hospital or the doctor's office for an injection. And that burden of therapy is one of the barriers that we have to address. The burden of disease is the other barrier. And for that, we're looking at developing a drug that can be effective. To get to effectiveness, you have to have adequate exposure. Exposure changes by age and size of the child, the ability to reduce the burden of therapy by giving an oral medication instead of an injection. Those are the kinds of things that we are thinking about. And it's important to be able to define a formulation, meaning the way in which the drug is delivered. Is it an injection? Is it a pill? Is it granules that go in food? Or is it a liquid that can be taken? These are important aspects to address the burden of therapy. And then the burden of disease, that's the metabolic aspect you're talking about, getting to the right exposure to be able to affect the disease. And it takes a significant efforts and technology to assess how much exposure to give to, for example, an infant. I think about 1 or 2 month old infant and the way in which their body uses energy versus an adolescent, an 18-year-old, 17-year-old, and the way their body uses energy. That affects the exposure and how much drug you need to give. Those are the kinds of things we have to look at as we're developing drugs for children, and it'd be quite different from how you do it for adults.
Very much so. And going back to what you were saying earlier about this notion of freshly designed endpoints, as it were, within clinical trials, and you mentioned also that oftentimes with pediatric patients, these are patients so young they don't have the ability to use their language, which is missing because of the age at which they're at, be that, as you've just been discussing, an infant or up to sort of toddler age. So although at the moment there is much discussion about shifting from endpoints to patient-reported outcomes, for example, perhaps you could just state it clearly for our listeners that such conversations are beneficial for the adult population. But when it comes to pediatric patients, and especially within this disease area, this wide-ranging disease area of rare disease, why that perhaps is a non-starter.
Yes, it can be very difficult to design an endpoint that measures the same outcome for an adult as for a child. If you have a patient-reported outcome for an adult, as you're saying, you might be able to use that same outcome in an older teenager, 16, 17, maybe 18 years old, but you get to school-age child or toddler, and you can't ask them a question and have them assess on the same scale. There are ways to translate some of those patient-reported outcomes for older children, but for younger children, it really doesn't work. And so we become more dependent on asking a caregiver to look at and report what they see in their child, or a physician to look at and report what they see on clinical exam. Those can still be observational outcomes, but they're not patient-reported outcomes the same way you would have with someone who can really speak to how they're experiencing their disease.
Thank you, Helen. So let's turn now to what you mentioned also earlier, which was shifting focus to the benefits that can come from tech. So if we now concentrate on BioCryst itself positions the company as, and I quote, a different kind of biotech company, and that in that it listens to and understands patients, helping to restore, as its website states, and I quote again, a sense of freedom for patients with hereditary angioedema and other rare diseases. I was just wondering if you could share for listeners a little bit more about this company ethos and the positioning just described.
Yes, I'll mention two different ways that we approach what we do that I think are very much wrapped up in our ability to deliver. One is in designing our programs, our clinical development programs, to make sure that we are meeting the needs of our patients. And the other is the involvement of patients in understanding what we're trying to do with the medicine. So on the first, when we design a program, as a scientist, there's a way of assessing what is needed to test a drug from a scientific perspective, what is needed to report in outcomes, either measures or patient-reported outcomes and questions that we learn from discussion with the regulators. But one of the things that we also need to understand is what matters to the patient, and make sure that we're measuring that in our clinical trial. For that, we need to be thinking about, how is this medicine going to be used by a provider, a physician, and by the patient or the parent giving something to their child who's ill? And we have to make sure that we're assessing that in a clinical trial. So we engage early with regulators, but also with patient advocacy groups to understand what matters to a patient and wrap that measurement into the program that we're designing. And the second piece, the patient advocacy discussions and understanding from patients themselves what they want. This is beyond a clinical trial. It's more understanding what is the burden of the disease and what is the burden of the therapy, and how can we bring something that might improve on both of those. So before we even start designing a clinical program, as we're starting to understand a disease and how we may be able to develop a drug for that disease, we are talking with patient advocacy groups, and we are sometimes talking with patients as well, to hear from them, simply understand and listen about what it is that changes their life with their disease, what are the things that are most worrisome to them. And we sometimes change direction in a program based on that input. For example, we might change the type of formulation that we're developing based on what we hear from patients before we even started our clinical program.
Well, that sounds long overdue, Helen. It's listening and acting upon what is listened to. So in summary then, just explain for us so our listeners go away with a clear message. Why is the time for action now? And how can serving the pediatric patient population through every stage of the drug delivery process lead to better adherence and more effective disease management?
I'll refer back to the two patients I mentioned at the beginning. As I mentioned, those two patients, their diseases now, there are more treatments available than when they were my patients. That's an example of how much can be done, and there's better treatment for cystic fibrosis, there's better treatment for sickle cell disease. There are many, many diseases that have no treatments yet, and this is just the start of understanding how we can improve that burden of disease and burden of therapy for children, and be able to bring therapies for diseases where children are currently hospitalized with serious conditions, but there's no effective treatment. There's a lot more to do. So there's urgency in developing drugs. There's also urgency in designing the programs to be able to better address the needs of patients so that we are actually changing the individual child's life, changing them and improving a parent's ability to take care of their child and giving them an opportunity to live a more normal life. That is absolutely critical to what we need to do as in the healthcare industry as we continue to strive to improve more patients' lives and more different diseases, but we are just at the start and there's a lot more to do.
Thank you, Helen. It's been a pleasure.
Thank you very much, Nicole.
And so that concludes another episode of the pharmaphorum podcast. You can find more information about this episode, including a download link and information about previous instalments at pharmaphorum.com/podcasts. The pharmaphorum podcast is also available on iTunes, Spotify, Amazon Music, Podbean, and pretty much wherever you get your other podcasts. Just search for pharmaphorum and press subscribe. Of course, don't forget to visit our website itself, where you can sign up for daily and weekly news and analysis bulletins. And do follow us as well on X or Twitter and LinkedIn at pharmaphorum. That's all for now. Thank you for listening.